Dr. Baliga here. This podcast is on the utility of famotidine in COVID-19 patients. Famotidine is an over-the-counter H2 receptor antagonist, a heartburn medication that has been used as possible therapy after Michael Callahan and colleagues in China reported that patients in Wuhan who happened to be taking heartburn medication seemed less likely to die from or be intubated during severe COVID-19. These observations have been published as preprint but has yet to be peer-reviewed. Hospitals in New York are currently investigating intravenous famotidine with hydroxychloroquine and are recruiting patients for phase 3 randomized trial for patients with COVID-19 who have critical status. The mechanism of action for famotidine is unclear at this time. Famotidine is thought to possibly bind a papain-like protease that is encoded by the SARS-CoV-2 genome and is known to be essential to the entry of SARS-CoV virus. However, none of the cell assay results so far support this hypothesis. The article in the preprint server is titled Famotidine Use is Associated with Improved Clinical Outcomes in Hospitalized COVID-19 Patients, a propensity score matched retrospective cohort study. The lead author is Dr. Daniel Freedberg, MD, MS. He is Division of Digestive and Liver Diseases, Columbia University, Irving Medical Center, New York Presbyterian Hospital, New York. In this article, the authors argue that in vitro, famotidine inhibits HIV replication, and recently, Wu et al. Using computational methods to predict structures of proteins encoded by SARS-CoV-2 genome and identified famotidine as one of the drugs most likely to inhibit 3-chymotrypsin-like protease, which processes proteins essential for viral replication. Therefore, these authors hypothesized that famotidine should be associated with improved clinical outcomes among hospitalized patients with COVID-19. To investigate this, the study authors performed a retrospective cohort study at a single academic center located at the epicenter of COVID-19 pandemic in the US. Complete methods are available. Patients are excluded if they were died or intubated within 48 hours of hospital admission. Adult patients were eligible for the study if they were admitted between February 25, 2020 and April 13, 2020 and tested positive for COVID within no more than 72 hours following admission. The primary exposure was use of famotidine, any dose, form of administration or duration, if famotidine was received within 24 hours of hospital admission. The primary outcome was composite of death or endotracheal intubation from hospital day 2 to day 30, that is intubation-free survival. This follow-up period avoided immortal time bias because the exposure was classified based on 24-hour period after hospitalization and the at-risk period began on hospital day 2. The investigators used Cox proportional hazards modeling on the full cohort and a matched subset was examined with propensity scoring matching to balanced baseline characteristics based on the use of famotidine. 1,620 patients met criteria for analysis, including 84 patients, that is 5.1%, who received famotidine within 24 hours of hospitalization. Home use of famotidine was documented on admission. Medication reconciliation, 15% who received famotidine, while hospitalized compared to 1% who did not. 28% of all the famotidine doses were IV. 47% were 20 milligrams, 35% were 40 milligrams, and 17% were 10 milligrams. Famotidine users received a median of 5.8 days of drug for a total median dose of 136 milligrams, that is from 63 to 233 milligrams. There were minimal differences comparing patients who utilized famotidine to those who did not. What were the study findings? 8.8%, that is 142 patients were intubated. 15%, that is 238 patients died. 21%, that is 340 patients met the composite study outcome. In crude analysis, the use of famotidine was significantly associated with reduced risk for the composite outcome of death or intubation. Log rank p less than 0.01. This association was driven primarily by the relationship between famotidine and mortality, and when those who died prior to intubation were excluded, there was no association between the use of famotidine and intubation. After adjusting for baseline patients' characteristics, the use of famotidine remained independently associated with risk for death or intubation. Adjusted hazard ratio 0.42, 95% confidence interval 0.21 to 0.85, and this remained unchanged after propensity score matching to further balance the covariables. Hazard ratio 0.43, 95% confidence interval 0.21 to 0.88. The investigators performed additional analysis. Use of PPIs were analyzed because PPIs are also gastric acid suppression medications with similar indications as famotidine. There was no protective effect associated with PPI. Adjusted hazard ratio 1.34, 95% confidence interval 1.06 to 1.69. Next, 784 patients without COVID-19 who were hospitalized during the same study were analyzed, and among these patients, famotidine was not associated with reduced risk for death or intubation. There were 24 deaths or intubations, log rank p equals 0.70. The maximum plasma ferritin value during the hospitalization was assessed to address the hypothesis that by blocking viral replication, famotidine reduces cytokine storm during COVID-19. Median ferritin was 708 nanograms per ml. Interquartile range 370 to 1152 among users of famotidine versus 846 nanograms per ml. Interquartile range 406 to 1552 among non-users. So p-value was 0.03. The authors concluded in this retrospective study, in patients hospitalized with COVID-19, famotidine use was associated with reduced risk of clinical deterioration leading to intubation or death. The study was premised on the assumption that use of famotidine represented a continuation of home use, but documentation of why famotidine was given was poor. The results were specific for famotidine. No protective association was seen with PPIs, and also specific for COVID-19. No protective association in patients without COVID-19. A lower peak ferritin value was observed among users of famotidine, supporting the hypothesis that the use of famotidine may decrease cytokine release in the setting of COVID-2 infection. The authors say a randomized controlled trial is currently underway to determine whether famotidine can improve clinical outcomes in hospitalized COVID-19 patients. Clearly, the study has limitations. It was observational, and the investigators cannot exclude the possibility of unmeasured confounders or hidden bias that account for the association between famotidine and use and improved outcomes. No samples were gathered, and the mechanism cannot be directly assessed. Finally, this was a single center study, which may limit generalizability of the findings. In summary, the authors say in patients hospitalized with COVID-19 and not initially intubated, famotidine use was associated with a twofold reduction in clinical deterioration leading to intubation or death. These findings are observational and should not be interpreted to mean famotidine has a protective effect against COVID-19. Randomized controlled trials are underway. This trial was brought to my attention by Dr. Benedict Joseph Molecule, MD, a gastroenterology specialist in Memphis, Tennessee. He's a senior gastroenterologist, and he has spoken to physicians in the Northwell Health System in New York City and is persuaded by the efficacy of famotidine in COVID-19 patients. Clearly, we need randomized clinical trials to confirm these observational studies.